Good morning, listeners and watchers. This is Lawrence Yang. I'm a family doctor in Surrey. I'm a QI learner and really passionate about improving the health system. And with me today, we have Dr. Harsh Hundal with me. Did I say your name right, Harsh?
Oh, yeah, you got it fine. My mom goes Hundal, and my dad goes Hundal. So even amongst the family, it's a little. We're fine with it.
Yeah, it's interesting how we anglicize our names. In Chinese, my name is Yang in
Yes.
Mandarin, but we always say Yang here, and that's how I say it. So speaking a little bit of family and origins, tell me a little bit about your origin story in quality improvement. What were your first memories of learning anything about QI science and its application to healthcare?
I think my first memory was uh, way back in Guelph. This is a quarter century ago. I was just left a small town of Coburg as a rural physician and moved to Guelph. I was being a house husband, and we got a phone call. As my wife was saying, the bank account's looking a bit thin. I got a phone call from a chief of staff who said, our rehab program, we don't have anybody to support the patients, and we're looking at amalgamating. Would you be willing to do that? And I
Mm,
said, sure, why not? And done that. I was an OT in a previous career, so I said, okay, I'll give that a go. And so I joined it, and we were basically taking an acute care culture and marrying it to a long-term rehab culture and moving it all to one site. And really, that's where the idea of involving people in shaping the change and looking for opportunities to improve grew out of. So we used an appreciative inquiry approach with the staff of what were their expectations? What made a good day? What did they want less of? And how did they see this unit working together to try and uh, build an excellent rehab program? And it all grew out of that. And then I would read, I think If Disney Ran Your Hospital was the big book at the time. Do you remember that?
David Chan or something, yeah.
Yeah, so I remember being sent off to the lecture session that the fellow gave, and then I got back and said, "All right, we're going to have team meetings, but we're going to have everybody in the team in the meeting, right?" So we had the housekeeper, the dietary aide, the not just the physicians and nurses, and then every meeting we had sort of monthly meetings. It would be, what are we going to improve? What can we do better at? What's a patient concern, or what's your concern? And some of the best ideas came from the housekeeping staff in reducing the number of bed moves for patients, reducing our linen costs. We took out our budget. The manager took out the budget and explained all the different budget lines to the staff and went over, this is how much we're spending on linen, this is how much we're spending on testing, etc. Um, and then there were ideas, and it just sort of grew out of that. It was like, uh, for example, we had all the patients fed at the same time. We do that still in Colony General in the rehab department here. And then we thought, well, we have short staffing. How can we optimize staffing, make sure our nurses get a break, and get a good experience for the patients? And I remember, actually, it was me. I said, what about like on a cruise ship? And I was told, hey, no, we can't do that because that's not the way we do things. And everybody had to pitch in. So I became the next morning the most expensive waiter, dietary aide in St. Joseph's history. I was serving meals to the patients, and by lunch we had ourselves cruise ship dining for the patients, and everybody's tension level went down. And it's just a simple solution, right? Nurses got their breaks, patients got a quieter environment to enjoy their meals, and far less stress on everyone around.
Wow.
So
And this St. Joseph's is this in Guelph, Ontario?
in Guelph, Ontario, it's a rehabilitation center in Guelph.
Oh, and you started serving uh, beautiful meals to everybody.
Yep, yep.
So it sounds like you were exemplifying kind of the quadruple or quintuple aim there. You were serving, you were improving patient experiences, you were involving patients in the design of their experiences. You ensured that the nurses had rest. You were making sure the health professional wellness was there. Um, it sounds like you had a little bit of that in mind already. I'm involved in teaching quality improvement now for about 5 or 6 years in the physician quality improvement program. Were you ever able to take formal training in quality improvement?
Actually, uh, formal training, I did the IHI modules. That was the formal training, and I did them when I um, rejoined Interior Health as executive medical director for physician engagement. And my first job was to help reconfigure the PQI program in IH. So I was dropped in as executive medical director for quality and patient safety for about 6 months. And part of that was I did the IHI courses. And more importantly, I went out and with the improvement consultants to meet with physicians and staff and really had conversations about how do we make this sustainable, right? Because just training physicians and quality is not enough. It's part of the way, but to sustain it, we really need the administrators and the staff learning as well, and to have patients involved from day one on the project, if possible. That's the way we get stickiness.
Hmm. I remember the first time I'd met you was at a quality forum, and you were doing that's the big British Columbia QI gathering with over 900 participants at the Hyatt in Vancouver, and you and some one of your colleagues was presenting on the concept of dyad leadership,
Hmm.
which is unfortunately still kind of not yet, we haven't all adopted that yet in our health systems, where clinical partners are partnered with administrative partners to kind of bridge silos and bridge perspectives in a collaborative approach to leadership. And that's still a new thing. It's like you could continue to talk about that and still inspire a lot of positive change around that. Um, so you've always been around this collaborative approach, and what kind of has given you that confidence that this collaborative team-based leadership approach is what's needed in healthcare? Was there a particular incident, a mentor that showed you this is the way, or is it just instinctual?
Uh, I think I have to go back to my days as an occupational therapist, and OT is based on a biopsychosocial model, and a lot of it, the patient sets the goals. And you work within a team with other therapists and the medical staff. So coming from that background was actually a really positive background for going into medicine. And in medicine itself, I found my greatest joys was actually seeing teams functioning really well, not just under stress, because, that's sort of like a litmus test, right? Quote unquote. Uh, Actually, from day to day, and to know that the ward clerk can raise their hand and say, "Hey, there's something not right," or "I've got an idea, guys. Why don't we do this?" And then you sort of and everybody treats each other respectfully, and I always found that really great.
I have so much appreciation for occupational therapists, and it's so interesting. You're the first occupational therapist I know who actually transitioned careers from OT into medicine. Tell us a little bit about that transition. What spurred it on, and how did you have the courage to leap to a different career?
Well, I was 30 years old, so I came late to medicine. I reached a point in my occupational therapy career where I thought, honestly, I couldn't see myself doing toilet transfers with patients when I was in my 50s. Okay. And I also realized there's quite a hierarchy, and that some of the people who are making decisions, um, God, how do I make it not sound like it's narcissistic? Um, I thought I could do a better job at the end of the day with the staff and with the patients, and given my experience. And remember, this is the 1980s, and it's a different time back then. The hierarchy was really well established in where I've trained, and so I didn't know what I was going to do, John. I simply quit my job, packed up my backpack, and I went to Europe for 100 days, and I wandered around, and then I was standing in the castle in Salzburg, Austria, and looking down at the executioner's house. And it was like just one of those moments, right? You suddenly have an epiphany and you say, why not medicine? You know, what if what I'm looking for is in medicine? To me, it's been the right decision in the sense that medicine gives us first of all, it's a privilege, right? To be a clinician, to be a physician is a privilege. But also, there's a place for everyone in medicine, right? Depending on your skills and your abilities, both in terms of emotional intelligence and all the other 16 different intelligences that people can have. There's a place for everyone, and there's an opportunity to make a difference. And I honestly think that's why people get into medicine. They get into medicine to care, and they get into medicine to make a difference. And that if you thwart those two drives, that's when you have disengagement, right?
Yeah, you get a disconnection from purpose.
Yes.
You know, you spoke a little bit about hierarchy, and I've actually heard you speak in some webinars about flattened hierarchy, about different ways of distributing leadership in teams and stuff like that. How did you come across that those viewpoints? And they're kind of novel, and they're not often things that everybody has access to in terms of literature about new ways of leading in a complex system. What are some of your inspirations around that? How did you come across those topics?
Um, wow. Um, First of all, I have idiot defiance syndrome, and uh, I also suffer from a bad streak of being anti-authoritarian, believe it or not. So don't treat me like an authority. Um, because I honestly do believe that only by questioning authority and the way we do things does any progress happen in society, right? Whether you're Copernicus or Galileo or Salk or whoever, you actually ended up challenging the mindset of the time, right? And I think that's how we get improvement. So one um, book that or series of chats I'd ask people to just take a look at is General Stanley McChrystal's. His uh, not so much his book; it's his story, but his aide de camp wrote an excellent book on how to go about flattening the hierarchy. And the flattening the hierarchy, the way you do it, ultimately comes to leaders. How does the leader approach what they do? So to me, leadership sets the table for the culture and the way that people are supported and facilitating the ability of people to do work. So in McChrystal's case, he's involved in a war and finding out that by the time his people could respond to the enemy, it was too late because the chain of command decisions had to go all the way up to the top back in the United States. And by the time an action had occurred, it was past time to be effect. And that has parallels to healthcare. When we look at decision making, when we look at
Absolutely.
when we want something to move forward, we offer up solutions. They disappear into the ethosphere, and we don't know what the response is and when the response will happen. So what he did was he actually adopted humility as a core leadership value, and he listened to a 19-year-old who was savvy in social media. And social media, if you look at it, is simply to a way of flattening those relationships between people. And what he did was every morning they would have sort of the information operation rounds, and this young person basically ran them. And he would set the stage by saying, I am here to support you, and provided opportunities to connect. So people had chats in the background. People in the United States could help a unit on the ground in real time and provide information and support. And they could provide intelligence back in real time. So the whole decision-making cycle sped up considerably. We actually had that for a bit at the beginning of COVID, if you remember. The decision-making cycle sped up. Unfortunately, now it appears that we've moved back to the traditional 6 to 2 year cycle of how decisions are being made within health systems. And that's, I think, part of the hierarchical structure and the inertia that's within a system.
Yeah, I recall that when in early 2020, when my hospital at Surrey Memorial Hospital, we knew that something was coming. We knew we had to prepare everybody. All these informal communication routes occurred, like WhatsApp chat groups, Signal chat groups. There was so much extra sharing of information that had never happened before, and
Hmm.
decisions were kind of made almost at like a hive mind basis. And there's new new information was circulating so quickly, and it felt like everybody was aligned at one point. It was
Yeah,
a very interesting response, and I think you're right. We are kind of going back to our slow, relaxed, and unfortunately, sometimes obtuse state
and very
in our
siloed,
change
right?
pace.
So one of the things in that time, Lawrence, was the ability to cross silos without penalty, right? Things did not have to be filtered up to the senior executive team, but actually you could pick up the phone and call someone or send out an email and get someone to respond. So I remember we got virtual care set up in 2 weeks, something that we talked about for over 20 years doing. Within 2 weeks, we had virtual care launched in Interior Health. We had at least 800 medical staff on board having appointments virtually. I mean, that's unprecedented, but it's the ability to communicate, it's an ability to cross silos, and it's the ability to place care in the center of that lens. Uh,
Yeah, go ahead.
Go on. And I guess the thing is, times of uncertainty are wonderful times because most of healthcare are uncertain decisions, right? They're not, you're not dealing with the known knowns within health system design, within programs, within delivery. Uh, there's very few known knowns. It's a matter of saying, okay, that worked good in 1984 under the circumstances. What can we do to make it better? Is there another approach? Should we really be providing the service in a hospital? Should we be able to deliver this at home? Is this the right person to deliver that service? What are the supports and that people need? So I sort of subscribe to this idea. There are four things people want, and whether you're a physician or whether you're a housekeeper, I think it applies. One is um, people want decision rights. They want to know, what decisions am I do I have the capacity, and that, I've been anointed to make those decisions. And if I don't make those decisions, who do I go to and know that they can make the decision? I don't want to keep pushing things up the tree or waiting for a decision, right? I want to know who are the decision makers and how do we access and how do we flatten that. Two is mastery. Nobody goes to a job, right? Nobody comes into healthcare as a physician, comes in the morning, goes to the emergency room and says, today I'm going to be a crappy physician. I am going to be so bad, I'm just going to be on this side of the line in terms of getting reported to the college. No one goes in like that. People want to go in and they want to do a great job, right? But they also need investment into their education, their training, and the expansion of their lenses, right? So I did a master's in public administration after medicine. And The great thing about that is that we get so used to seeing things through our own lens that it's actually like, oh, I never thought about it that way. I never thought about it in terms of this particular philosophy or this particular viewpoint. So if we can open up our lenses and be more inclusive, we get better. But we need to invest in mastery and in competence. The third thing people want is to have um, the word belonging. We all want to belong. Work life is a pseudo family life. We want to connect. We want to do that. And I think the example I always give is the emerge physician who said, my manager doesn't understand at all the issues that we deal with and whatnot. And I remember saying, hold on a second. What do you know about her? Why would she come in day after day to hear you complain, patients complain, staff complain? What keeps her going? Go for a coffee and don't talk about the problems. Talk about what do you have in common? And I ran into this physician about 3 months later and said his best conversation that he'd ever had. He'd known this person, quote unquote, he'd worked with this person for 3 years. He had no idea that her values were the same as his, right? And from there, he goes, we started working together much better, right? So until we know. So developing belonging is important. And the last thing is beneficence in leadership. The idea that leadership exists to serve people as opposed to decision control, right?
Mm.
And believe it or not, the Chinese came up with that idea in the semiconductor, doing a quality study of semiconductor chips in two factories, one which the leadership employed a beneficent approach of listening and acting and on consistency of listen and act, and the other one was a very top-down approach. And the number of defective chips was higher in the top-down approach, and the quality of the chips was much, much better in the one in which people were actually involved and saw their leaders and managers as people who cared about them as persons, as opposed to them being tools that allow you to reach targets.
Wow. I wish more people knew that. In so many of the tables that I sit at, I get people who kind of have this narrative. We are in a crisis. We need to get into emergency response. Things need to change now. We got to do top down, and we got to just tell them what to do, and they just got to follow. But you're saying that it doesn't work, does it?
It doesn't work. It's temporary. You're basically uh, trying to force a function through. In the long run, I could probably predict that you're going to have increased turnover, right? You're going to lose resources, which is people, right? Over 70% of our healthcare is spent on human beings, and losing them is, as you push this crisis mentality, you actually exacerbate the sustainability issue.
70% of our expenditures are on our
People,
professionals.
we pay people wages, right? 70% of, at least in hospital, is nursing, right?
You mentioned this concept of getting different lenses, wishing other people saw other things. If if there if you had a chance to download a perspective into physicians, not that you would want to, but let's say if you could,
Yeah.
some of the physicians in your area who hold a certain perspective, you want them to see another side. What would that other side be? What's something that you wish physicians on the ground knew about healthcare systems?
Um, I think the first thing I'd start with, what would probably be most meaningful to them, is that, do you know how hard it is to be an administrator? It,
Ooh.
it is. It's the equivalent of being stuck in a foxhole in no man's land in World War I, right?
You mean you're not
Y-
just twiddling your thumbs in meetings and just
No,
checking
no,
your email?
no. Sometimes one is attending meetings because uh, it's part of the corporate culture, right? Even though one knows that it's not doing much. But if you don't, there's a price to pay. Okay. So the price to pay for our administrators are one. So here you are in your foxhole and you've got this great idea, right? Should you raise your hand and work on it? Because if you fail, if you embarrass the vice president, it's the end of your career, right? You're going to have to look for another job somewhere else. Health systems, the way we structure them, incredibly risk averse, and a lot of it's reputational risk that's focused on, right? So there's a big pressure from above not to fail. But we know in QI, failure is normal. But we try and control for factors, right? We have balancing measures and whatnot, but we, make reasonable choices. So from an administrator's point of view, their day can be with patient complaints, staff complaints. Uh, when things go wrong, the PSLS, that's a patient safety learning system, which is a reporting system, and lots of report writing. Because there's one thing bureaucracies love to do is document reports, whether or not things actually get done or improved, as long as it's documented and sent, upwards. That's the tough thing. And the tough thing with administrator is that if you challenge a viewpoint, you actually have the risk of losing your job. And how many health authorities do we have in BC?
6, right?
Yeah. So you have to move to find another job, and maybe you find it in BC, or maybe you go to another province, right? So you uproot your family. So risk plays a huge factor in what administrators do, and reporting requirements take them away from what most of them actually got into it in the first place, is to actually improve care and to help people grow.
Wow.
So I'd say if I was to start with that, I would say that's the first thing. Um, do take your administrator for a coffee and find out about their lives and what matters to them, and the tightropes that they have to walk in order to get things done.
Hmm. What is a dominant narrative in administrators about physicians that you wish they could change? What if you had a magic wand and administrators suddenly understood
Ah,
this as
okay.
clinicians? What would that?
Physicians always cost us more money. When a physician has an idea, it always costs us more money, right? That's narrative. I think that the way around that narrative is to simply say, well, shouldn't we be working on the idea together? And let's find out, does it really cost more in the long run? Okay. So did thrombolytics end up costing more in the long run,
Ooh, I don't know.
right? Did they cost us more? Does um, you name it, any advance at the time was probably looked upon as a very costly measure. And there are other things that we've done that we've said, well, we're doing this, we're giving felodipine to, is it felodipine? God, I think it was. One Archie Cochrane did the analysis on that. The standard of care at the time was to dampen out cardiac arrhythmias. And frankly, we were killing more people by doing that. But that was our standard of care.
Hmm. So I think what you said is that there are clinicians that have great ideas that cost a lot of money, but some of them could actually save money in the long term. If
Yeah, I think you have to figure out a mechanism of um, um, sort of filter system, a series of filters to be able to say, okay, this is the one we back. Okay, these are the couple that we back. Um, I also think that an idea that works in site A won't work on, may not work in sites B to G, because the cultural context isn't there to support the change. And I think that was the surgical checklist experiment in Ontario, that let's all bring in surgical checklists. But how come we're not getting the improvements that these people got, because the actual change was in the relationships at the site and how they work together and how they approach safety together. So that's a shift from safety one to safety two culture. And I think we're still within that paradigm shift, right? It's the compliance versus the more reconciliative, uh, just approach that says, okay, let's look at this from a point of view of fairness, and let's take a look at this in terms of uh, how can we support change.
Mm. So there's a difference between a tool, a solution, and actually the culture, the energy behind
Yeah.
it, the actual application of that tool. And
So yeah. So one of the things we do, we like to simplify problems, and we like silver bullets, and we like tools, right? Whether it's a checklist or whether it's um, you know, if we all did this if we all did stretches at the same time across the entire health authority for 5 minutes, or sang a song together, things would be better, right? It just doesn't work like that, right? Uh, health health system delivery is the most complicated enterprise that human beings can be involved in. All the different pieces, and it's actually quite amazing how often we get it right. But getting it right is dependent on the clinical people and their support people, recognizing when mistakes, adjusting the approach, changing the way you do a particular surgery, the medication, adjusting to the patient's values. Maybe Mrs. Jones really doesn't want a statin, you know, or need a statin. Maybe that's not as important to her as being comfortable,
mm,
right?
so you've been involved in patient care
Hmm.
uh, as a physician, as an occupational therapist, and now you found yourself in leadership positions for quite a few years. How many years has that been in? Would you consider yourself to have been in leadership positions?
Wow. Not counting medical school, probably about 20 years in
Wow,
various leadership
that's,
positions.
that's a
And I
long
still do clinical. I'm a rehab GP at Kelowna General. So,
time
uh,
there.
and so, yeah, and it's interesting. And what comes around goes around, and you sort of like go, yeah, I saw that in 1980, 1990 something. And you go, oh, yeah, they tried that out. It worked for about 6 months. Let's see if it'll work this time.
What? So, I mean, you're patient facing relationships. You have physician facing. You have other administrator, other leaders,
Yeah.
health ministry. What is something that you wish that the patients knew about the health system? That
That, yeah, there's a lot of great people in healthcare, right? Um, and they're doing the best they can. And, I mean, and that includes people in the ministry, people in administration, people in medicine. The, the fundamental thing to me is that healthcare isn't really a system, right? Healthcare is, um, those old hospitals. I trained at St. Joe's in London, Ontario, right? And St. Joe's started off as one house that the sisters ran. And then they added on new buildings and new buildings and new buildings. And you could wander around in the tunnels in St. Joe's, connecting up building to building. And at least when I finished training, nobody had come to the point of saying that sometimes you need to actually knock the whole thing down and look at what is design in the sustainable design in the 21st century for healthcare. What would it look like? What would what would we have within our walls, and what would we have outside? How do we actually support home health, right? Because hospitals are very dangerous places to be a patient in. The the possibility of things going wrong hasn't changed. in 20 years. Still 1 in 10 chance or so of misadventure in a hospital. So, how could we make care really closer at home? Do we have the right mix of people? Virtual care, where do we use it really well? How do we use it really well? And where do we not use it? Right? Um, how do we integrate home monitoring? How do we actually have an idea of building a system with a nerve, you know, a circulatory system, communications, in other words, a nervous system? And so when you look around, you see that there's all these pockets of really cool stuff that people have done, like home care in the Netherlands, where basically one group has created a social network of healthcare providers. And this is in home health. And a nurse or a home health worker comes in, sees a wound, and he or she may not know how to take care of it, but they could take a photo and send the directions and post it. And then another nurse could say, "Hey, I've dealt with that kind of wound. Here, this is what you do," and talk them through it. So, how do you design that just in time learning as well as continual investment in people over time? Right. So, we have these conversations here and there, bits and pieces, but how do we actually bring it all together? Because sustainability, Lawrence, that's the future, right? That's now. That's the environment telling us, right? Hospitals, incredible wasters of energy and water and resources. So, how do we get the best out of that, but also know that how do we have a more mindful approach to primary and community care? That should be the center of where care occurs. And I'm biased, I admit it. I'm a family physician by training, but I think the First Nations had have it right that it's the fundamental relationship over time between human beings that grounds us in the sense of community, and that allows us to have a sustainable approach to whatever we do.
Yeah, I've heard you speak and mention planetary health before and cultural safety. And I noticed that your background, you have elements of nature in there. You have the eagle. I think I see a narwhal
Yes,
and a rainbow and musical instruments and maybe a representation of an indigenous person and some other birds there. Speak to us a little bit about that and your learning journey around cultural safety and humility and reconciliation. Uh, what what hits you when you think of that?
uh, I think what always hits me is the stories of children. Okay, so one of the reasons I didn't go into pediatrics was essentially because the amount of anger I feel when I see children who've been victims of abuse. And then to know that this is a context of government policy, right? This is cultural genocide. I mean, if you're a kind person, you can't help but say, hey, hold on a second. This trauma transcends generations. And yeah, I'm an immigrant. My family comes from India, etc. Um, but even then, coming into this environment in British Columbia, is saying, we can do better by indigenous peoples, you know, and we can learn a lot and we can support them and be able to say, you know what, we need to do better. We need to um, really question that colonial mentality of we know best. And I think that actually ties back to the whole concept of power dynamics and hierarchies. Our healthcare system is built along the same lines of power and control as a military from the 19th century, right? It's very much a top-down approach. So how do we break that, right? How do we let the voices of our First Nations, our marginalized individuals, people with HIV, the homeless, be involved in shaping solutions and knowing, as we do know, is that most of the determinants of health are actually outside healthcare, right? So if we're going to really do this well, is how do we integrate social service and health service? Because as a family physician working in a small town, 30% of problems that people had that came to me were social issues. And as a family physician, I basically acted as pointing them in the right direction, not necessarily having solutions and keeping my fingers crossed that our social system would pick things up. When 1 in 4 children could be diagnosed with a major, um, you know, psychiatric disorder, uh, seeds of age below age 14, right? Shouldn't there be a tighter linkage between healthcare and education? So I think that's again comes down to the idea of breaking down silos and working at solutions at the local level and finding some way of amplifying positive change. I think mostly with the lesson I learned was as a medical student going up to North Bay and meeting a person who'd been flown in, a person who was Inuit, had been flown in, and she didn't make any eye contact. And we just sat there for a while and didn't say anything. And then my preceptor said, "That's okay that you didn't talk. It's going to take a while. You're going to have to go back every day. And just because people don't make eye contact with you doesn't mean they aren't being truthful, you know." And so it was just different cultural perspectives you have to take into play. Yeah,
Thank you for that. That resonates a lot. Now, you have been in leadership for quite a while, 20 years, you said. You've been in the medical field even longer, in the patient service field even longer. If you could go back and speak to yourself, let's say you're just starting to take on your first leadership position in the health system,
right.
what what is a point of wisdom that you would share with your past self?
I'd say same thing I say to my residents. When you first come out, everybody's going to want you to do something. Learn to say no. Uh, be very clear about what your values are, what your beliefs are, and the principles with which you live your life. What matters most to you, and balance that. Right? There's always more to do. Leadership can be like a ravenous monster in a cave and just take up more and more of your time. Uh, but you need to set boundaries and care about. The line I always use is I've seen surgeons have heart attacks during the middle of a surgery and then close up the patient and then walk down to the ED and say, "I think I've just had a heart attack." I've seen a respirologist who developed pancreatic cancer and is gone in 3 months. And the biggest question that was asked was not so much, "Oh, that's sad." It was more like, "Who's going to fill the spot on the call schedule?" Okay. So it sounds like a terrible thing to say to people, but in healthcare, you're not indispensable. I'm not indispensable in healthcare. There'll be somebody else to do the work, or the system, or the people who make decisions in this strange collection of systems will need to find another way to do things. And it can be good for them to feel a little pain. Ultimately, at the end of the day, the people you love are the people that should matter the most, and my spouse is a fantastic person, much smarter than me as Em. And I have 3 children on the autism spectrum, and I've learned so much from them in terms of appreciating minds that are different,
Wow.
right? What did we learn about autism in medical school? It was a afternoon lecture, I remember sitting there about a child that was fixated on the color purple. And that's all I learned about autism in medical school. So now I look around and say, well, 1 in 65 children, boys entering, sorry, 1 in 65 kids entering school will be on the spectrum,
Wow.
right?
One day, as you said, we'll each be gone. And what
Hmm.
is, what is the thing that you would hope that those that you have mentored, your residents, your trainees, what would they celebrate about you?
Whoa, is this eulogy time? I don't think so. Uh, kind.
Kindness. Hmm. Simple.
Yeah. Tom Wood, respiro- respirologist in London, Ontario. Uh, he was the first, I was a medical student, and he was the first preceptor I was put together with, right? And went around, saw patients, and then he sat down and he goes, Harsh, one word of advice, be kind. People will forgive a lot if you are kind and listen. I guess it was 2 words of advice, and listen.
From all of your colleagues and through the grapevine, I've heard so much about your kindness. So I love that you took that to heart. Um, what is a professional achievement that you're proud of? You know, that, wow, I can't believe we got that done.
Oh,
Was,
navigate.
what's navigate?
The Emerging Medical Leaders Program that Mike Artel and I launched in Interior Health. What we proposed is being a medical leader is incredibly lonely, Lawrence. Like I've been a chief of staff.
Yeah, they call
Uh,
it the dark side. They say,
the
oh,
dark side, right? You're no longer one of the gang, kind of thing, right? And it's incredibly lonely, and it's for clinicians. Uh, we go, we have no training. We're expected to be leaders, but we don't understand the health system. We don't understand how governments make decisions. What are the decisions that drive other decisions within healthcare? Uh, and we have some training, but we don't have enough to be effective coming out of medical school and residency. Okay, as leaders. So Mike and I sat down and we had this. This is when he was recruiting me to be executive medical director, and this was in the Blends in Kelowna. And we were having coffee, and we said, let's think of all the skills we screwed up in as medical leaders, and we built this staircase. And I went and I shopped that around at Doctors of BC, and Rob Hewlick at Doctors of BC said, BC said, if you could teach people the bottom part of the staircase, 80% of our problems in Doctors of BC we wouldn't have to deal with,
wow.
all right? Because they would have had the skill set to be able to solve them on their own. And so we launched it. And the essence of it is building community, right? So building a community of supportive individuals in medical leadership. And that's what we've done. We're in a second cohort. Already the magic happens so quickly. They start connecting and it's a very positive group. But if you think about it, Interior Health is the size of England, Scotland, and Wales, right? It's
Wow.
huge, 22 acute care sites. And so having people from all over Interior Health, all different disciplines, 50-50 specialists and GP, rural, urban, male, female, etc., all having them in one room and then watching them connect with each other, have very candid conversations and learn skills and learning the importance of vulnerability as as an essential part of being a good leader, and listening um, and helping people see bigger pictures and improve. You know,
Wow.
it's I think that's probably achievement wise, yeah, and it's a incredibly close group of people.
What an amazing program. I have not heard of anything like that in existence, outside of maybe Dr. Brene Brown's work. That sounds fantastic. And hopefully that can spread and scale.
Oh, we hope so. But I mean, the proof is in the pudding. The administrative, when the first group of navigators after the second session started attending meetings, the administrative partner said, "Wow, what happened to these people? The way they speak, the way they approach problems, the way they calm meetings, the perspective, the maturity all of a sudden that occurred." And watching people who were basically thinking of quitting or angry suddenly grow as individuals. You know,
Wow. Turning the passion from just anger and non-productive stuff into productive energy. Wow.
yeah, because people are angry, they actually care.
Take care.
You don't get angry over things you don't care about, right? So how you have to understand it. What is the frustration, and what do they need to take that anger to get those skills and get those connections? And I think ultimately, one of the things we should endeavor to do, and I think we've lost it in some degrees in healthcare, we need to move away from the machine model of healthcare, the sausage factory, and move to the community model that
Mm,
we're building communities of caregivers. And how do we support communities of caregivers, which I think really does fit in well with Helen Bevan's work in the NHS,
yeah.
right?
Helen Bevan's a hero of mine. I took the School for Change Agents, which just started its current iteration. Beautiful
Excellent.
teachings, beautiful teachings.
I had all the members of my physician engagement team. I said, guys, you've all got to do this. This person is awesome and you will learn more.
Yes, Helen Bevan. We're approaching the end of our time. I have two more questions for you.
Go on.
First of the two are, what innovations have you seen in other health systems that you wish we might be able to implement somewhere in Canada?
Wow. I really like that a social network of care, of which in home health, right, in the Netherlands. So I'm going to probably butcher the name. It's Bloodzorg, which is the home health.
Not the one where the
Which is
senior citizens play with the preschool kids and stuff like that?
that's a different part. But
Okay.
Bloodzorg it started off with a small group of nurses, and it's a flat hierarchy. Roles change within the small group, and once you get beyond, I think it's 8 to 10 nurses covering an area, the team splits and they grow out that way. So it's a more of an organic model, right?
It's like
So
it's
it's
like
like
a
cell
bunch of money.
division,
Yeah,
but 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 the standard communication system, the expectations, the alignment is all there, and a very flat hierarchy. I think there's, don't quote me on this one. I think there's like maybe 10 leaders for the whole system. That's a head office, right? With 20,000, 20? No, 14,000 employees. I might have those numbers wrong. I thought that's pretty good. Cool. I think there's a hospital in St. Louis that's pretty much all virtual. And you can see some really cool virtual stuff. Um, Particularly one site, it's covering night times is really difficult in the ICU and
Hmm.
medicine. And I love this idea that they actually pay their staff to go to Australia. So they go down for a month and they stay in Australia and cover the night shifts for the staff that are in the States.
Wow,
It
that's
works out less expensive, and the
global
people have a
teamwork.
nice 1 month vacation or whatever in Australia. There's some clever things like that. Just thinking outside the box.
Wow, I love that one. It reminds me of the Nighthawk system for radiology. Yeah. Yeah. Final question, and
Go
I
on.
might add on something. What brings you hope about healthcare in November of 2022? What brings you hope?
Oh, I think it's what gives me hope. I think it's the younger generation gives me hope. The new leaders coming into the system. I just had a wonderful chat with a new young leader, and just realizing how much more balanced this person is than I was when I came out. That they really had
Boundaries?
their boundaries. They had boundaries in place, and they had, this is family time, and that's important. And I thought, well, well, when I went through residency, it's not uncommon to be up for 3 days straight. Um, to sleep in your greens and naps. And struggle your way through, and that was part of the program, right? If you develop pneumonia, oh well, it's so sad, and that's just the way it went. Just give yourself some IV fluid, but take your bug juice. But I mean, it's that was the training environment at the time when I trained, and the expectations it set in people was superhuman, and the cracks were already there, you know. Um, but now seeing younger leaders come, uh, women as well, who bring a tremendous degree of empathy. Actually, no, I'm not going to use the word empathy. I think the word is compassion in terms of others and in terms of a sense of community as to what they
Mm,
support. And I really like their focus in terms of environmental sustainability, but more important, life sustainability, because they're in it for the long run. So, how do you have a sustainable life, a sustainable workplace, right?
Yeah, that is hopeful that there's intelligent young leaders that actually have a concept of an ideal balance and sustainability of their own lives and their interconnectedness
Yeah.
in team-based leadership. Yeah, so,
And they're incredibly networked, right? How I thought it'd be fantastic. Privacy won't let us do it, but to take a look at the email exhaust of individuals in an organization and find those connectors, right? And then figure out a way to reach them and be able to say, here, we'd really like to do this. For example, the palliative approach. How can we spread the palliative approach better in care? Can you communicate it out? We'll teach you a little bit about it and whatnot. Can you take this message out?
I love it. You've spoken about flattened hierarchy and networks and social networks multiple times during this discussion. Fantastic, hopeful things of potential of connectedness in the future.
And I think we need to get out of um, we see this siloing within an organization, but between organizations. And so, how do we create better partnerships and actually kind of blurring between, um, you know, private, public, NGOs, etc., around you know, around issues and concerns, right? I
Mm,
don't see any reason why, um, for example, if you had an emergency room, right, and you had an advisory group, uh, that would help you figure out how to make things better. Wouldn't it be great to have First Nations there,
yeah.
right? But how many people actually have First Nations as part of an advisory group for each service? I think that's actually cool. That there's actually a whole movement of that in the US, and I think
Mm,
that's a cool movement.
cool. It's disruptive in a good way. Yeah.
Yeah.
Mhm.
And sometimes what people want is a lot different than what we think they want. If you sit down with patients, actually, if you sit down with most people, what would be the most important thing you want to get out of a healthcare system? Probably the first thing would, I want to feel that I've been respected and listened to. So, how do you build a system that respects individuals and families and their lived experience?
Mhm. That's an inspirational question that we can reflect on as we close today. Final question. If people want to reach out to you and connect with you, ask you more questions, is that something you're open to? And if yes,
Sure.
how might they reach you?
There's always my email address, harsh.hundal at outlook.com.
Okay. Are you on any social medias or anything right now?
Oh my God, Lawrence, I'm just so hapless in doing that social media. My son's a social media monster,
Okay.
but you know what? Maybe I will figure it out.
And you'll get in a future episode.
Future episode. Maybe I'll just open up. Oh, don't get me started on Twitter, but maybe I'll figure out some way that people can simply connect or do a blog or something.
Well, I've really appreciated, and I know that our listeners today really appreciate you coming with your authenticity and your wealth of experience. And number one, your compassion that was so evident. Um, yeah, your reputation precedes you. All of my colleagues who have worked with you have really appreciated your leadership, and hope you continue to do so in
Oh,
whatever way that you find.
thank
Yeah.
you, Lawrence. And one final piece of advice. Um, the world is beautiful out there, right? Don't just rely on the internet. Actually, until you meet people in their place, recognize their context, and share a meal with them, that's when you really connect. And that's really important for your learning. So, numbers on a spreadsheet aren't enough. Actually, connecting with people and understanding that there are so many people out there that really care about creating good healthcare. And I've seen that in community after community.